Nocardia is a genus of gram-positive, branching filamentous rods that are often found in soil. There are over 80 species of Nocardia, and around 30 of them cause disease in humans. And the most notable ones are Nocardia asteroides, Nocardia brasiliensis, Nocardia syriaca, Nocardia farcinica, and Nocardia nova. Nocardia causes a disease called nocardiosis, which has three major forms: pulmonary, cutaneous, and disseminated. Okay, nocardia is a rod shaped gram positive bacteria. We've got that part down. And this means it goes purple when gram stained. When there's many of them, they arrange themselves in the shape of purple branching filaments. They are obligate aerobes, meaning they need oxygen to grow. They're also non modal and don't form spores. Wait a minute. That sounds suspiciously like Actinomyces israelii, doesn't it? Another group of rod shaped gram positive filamentous bacteria with a lot of other similar features. So, to distinguish them, an acid fast stain, also called Ziehl-Neelsen stain, is done. With this test, a red dye called carbon fuchsin binds to lipids in the cell wall, coloring them red. Then, alcohol is applied to wash out any dye that hasn't colored bacteria, and a second dye, methylene blue, is applied. Now, nocardia is a weak acid-fast bacteria, which means that a less concentrated solution of alcohol is needed during staining, and that's because the mycolic acids in its cell wall have intermediate length. So, because it has plenty of lipids in its cell wall, it retains the carbon fuchsin, and it looks red under the microscope, making it an acid-fast bacteria. On the other hand, in bacteria who don't have a lot of lipids in their cell wall, like A. israelii, all the red dye is washed off by alcohol, so it looks blue under the microscope, making it a non-acid fast bacteria. Also, nocardia can be visualized with auramine rhodamine stain using fluorescence microscopy, which can show a reddish yellow fluorescence. This stain is not as specific as Ziehl-Neelsen stain, so it has more false positive results, but it's more sensitive, so it has fewer false negative results. And it's also inexpensive. So, the auramine rhodamine stain is often used for screening. Another difference is that nocardia is catalase positive, so it makes an enzyme called catalase, which converts hydrogen peroxide to water and oxygen, and also urease positive, which means that it produces an enzyme called urease that can break urea into ammonia and carbon dioxide, whereas A. israelii is catalase and urease negative. Finally, nocardia species grow on routine media, like blood agar or chocolate agar, on selective media, such as modified Thayer-Martin agar or BCYE agar, on mycobacterial media, like Lowenstein-Jensen agar, and on fungi media, like Sabouraud-dextrose agar. Nocardia forms white, yellow, or orange long branching filamentous colonies with a powdered aspect, which usually takes 3 to 5 days to grow, but sometimes it may take as long as 2 to 3 weeks. Now, nocardia has a low virulence, and therefore, nocardiosis occurs more often as an opportunistic infection in immunocompromised people. It enters the body through inhalation or skin trauma, and once inside, it's ingested by macrophages. Inside macrophages, it gets wrapped in a vesicle called a phagosome, which normally merges with lysosomes to form a phagolysosome, inside which bacteria are killed by lysosomal enzymes. However, the cell wall of nocardia contains a cord factor, or trehalose dimycolate, which is a glycolipid that inhibits phagolysosomal fusion. Okay, now another immune system weapon is that neutrophils and macrophages destroy invading bacteria by generating a bunch of toxic oxygen radicals, such as superoxide, which results from oxidative metabolic burst. But nocardia makes two enzymes that break down these toxic oxygen radicals. First, there's superoxide dismutase, which breaks superoxide radicals into oxygen and hydrogen peroxide. And since hydrogen peroxide is still harmful, nocardia also makes catalase, which breaks hydrogen peroxide into water. Now, in pulmonary nocardiosis, the presence of nocardia triggers an inflammatory response that calls more macrophages to the site of battle. As more of them make their way there, they surround the bacteria from all sides and form a granuloma, which prevents it from spreading. In the center of the granuloma, there's caseous necrosis, which literally means cheese like necrosis, because the tissue in the center dies off and it's soft, white, and looks a bit like cheese. And it also tastes like cheese. Like, it doesn't taste like cheese. That was a joke. Okay, now pulmonary nocardiosis is the most common type, and it's usually caused when a species called Nocardia asteroides enters the body through inhalation. Pulmonary nocardiosis can be seen in immunocompromised people, such as those with HIV infection, malignancy, chronic granulomatous disease, which are associated with low numbers of granulocytes, or in people with underlying lung disease, such as chronic obstructive pulmonary disease, cystic fibrosis, or bronchiectasis. Pulmonary nocardiosis can progress to pneumonia with cavitary lesions, pleural effusion, or fluid in the pleural cavity, and empyema when there's pus in the pleural cavity. Disseminated nocardiosis is usually a complication of pulmonary nocardiosis, and the bacteria most often spreads to the central nervous system, causing meningitis or brain abscesses, or to the heart, causing endocarditis. Cutaneous nocardiosis, on the other hand, is caused by Nocardia brasiliensis and usually affects immunocompetent people after the bacteria enters the body through skin lesions. Cutaneous nocardiosis has three clinical types: superficial skin infection, which can progress to cellulitis or inflammation of the subcutaneous tissue, and skin abscesses; deep skin infections, specifically mycotomas, which are chronic and progressively destructive infections that affect the skin, subcutaneous tissues, muscles, and may even reach the bone; and finally, there's lymphocutaneous infection, when the bacteria spreads to lymphatic vessels and may form lymphatic abscesses. When regional lymph nodes are affected, lymphocutaneous nocardiosis is called sporotrichoid nocardiosis because of its resemblance with a fungal disease caused by Sporothrix schenkii. Now, symptoms depend on the type of disease. So, with pulmonary nocardiosis, there's fever, cough with sputum production, shortness of breath, and hemoptysis, or blood in the sputum, if there are cavities in the lungs. With disseminated disease, there can be symptoms of meningitis and brain abscesses like fever, headache, a stiff neck, and altered mental status, or endocarditis, like fever and new heart murmurs. Finally, skin infections. With cellulitis, there's erythema or redness, tenderness, and purulent drainage, and with abscesses, there may be local redness, heat, swelling, and pain. With lymphocutaneous infections, lesions progress along the path of dermal and subcutaneous lymphatics, and with mycotomas, there's swelling, deformation of the affected area, and multiple drainage orifices that ooze pus. That sure doesn't sound like fun. Diagnosis is done by identifying nocardia in a smear or a culture from respiratory secretions, skin biopsy samples, aspirates from abscesses, or CSF and blood in case of disseminated disease. When pulmonary nocardiosis is suspected, a PPD test should be done to rule out tuberculosis, since the symptoms are quite similar. A chest x-ray can be done, which shows irregular nodules, cavities, pulmonary infiltrates, lung abscess formation, or pleural effusions. Also, a brain MRI can be done to diagnose brain abscesses, and an echocardiogram can show bacterial vegetations on the heart to confirm endocarditis. Treatment of nocardia infections is done with sulfonamides, and the drug of choice is usually trimethoprim sulfamethoxazole. Alternatives include imipenem, amikacin, and linezolid, which are usually given in severe cases. Alright, as a quick recap, Nocardia is a gram-positive, branching, filamentous rod bacteria that is often found in soil. It's a non-modal, non-spore-forming, obligate aerobe, catalase and urease positive, weak acid-fast bacillus that can be visualized with Ziehl-Neelsen and auramine rhodamine stain. And it can grow on multiple medias into white, yellow, or orange filamentous colonies with a powdery appearance. It has a few virulence factors, such as cord factor, catalase, and superoxide dismutase, and it uses them to avoid the immune system. It causes a disease called nocardiosis, which has three forms: cutaneous, pulmonary, and disseminated. Diagnosis is done by identifying bacteria in a smear or a culture from respiratory secretions, skin biopsy samples, aspirates from abscesses, or CSF and blood in case of disseminated disease. And treatment is done using trimethoprim sulfamethoxazole as the first drug of choice.